Started. Thank you so much to everyone who's joined us today. We really appreciate you sharing our time for this Masterclass webinar. It's our honor here at McGraw-Hill to present in partnership with Sigma Theta Tau, Dr. Gaea Daniel, as she talks to us today about health equity. It's more than a catchphrase. So I am going to introduce just a couple pieces of housekeeping, and then I'll turn it over to Sigma Marketplace Manager, Darren Lowe, so that she can talk a little bit about Sigma and also introduce us to Dr. Daniel. So the couple pieces of housekeeping I have, first things first, I promise you are all muted and your video is off. So do not worry. That said, if you have any questions for Dr. Daniel or for any of us here as we go through the session today, please do put those in the chat. I will be monitoring that chat, and so will my coworker from McGraw-Hill. I said it right at the top of the session, but just to introduce myself again, I'm Kaylin Creason, and I am a librarian with McGraw-Hill, so I am always here to answer your questions as well. We'll put some contacts at the end of the session. Yeah, and I think that was actually it. Finally, there will be time for questions at the end. So without further ado, let me turn it over to Darren.
Well, good afternoon, everyone. Thank you all for joining us for this wonderful masterclass with Dr. Gaea Daniel. So I wanted to just tell those of you that aren't familiar with Sigma Theta Tau just a little bit about
you,
Sigma.
but that might just be me.
Is there echoing?
I hear you fine.
Okay, good. Just a little bit about Sigma Theta Tau International Honor Society of Nursing. Next slide, please. Sigma Theta Tau was founded in 1922 by 6 nursing students at Indiana University. It was one of the largest, is one of the largest professional organizations, nursing organizations in the world. We have approximately greater than 100,000 nurse leader members globally across 600 chapters and residing in greater than 100 countries. Our membership is by invitation and application, and it's based upon academic merit through undergraduate and graduate level all the way up to terminal degree or leadership qualifications. And then we are an accredited provider of nursing continuing professional development programs. And we publish award-winning books, and we also have 2 high-ranking peer-reviewed journals. Next slide, please. So just a little bit about our why. Again, we have over 100,000 nurse leaders from around the world that are proud to call themselves a Sigma nurse. I am a Sigma nurse. I was inducted into the organization quite a number of years ago, and I won't tell you how many years that is because then I'll be giving away my age. So just know that I was inducted and proud to be part of the organization. But our vision is connected, empowered nurse leaders transforming global healthcare. Our mission is to develop nurse leaders anywhere to improve healthcare everywhere. Next slide, please. Again, more of our why. We have a global value statement, and we are an international community of nurses dedicated to the advancement of knowledge, teaching, learning, and service through the cultivation of communities of practice, education, and research. And I know that we do have somebody from, I believe, Oceania here, and welcome. I know it's nighttime there, and if there's anybody else from the other side of the world, welcome, and thank you for staying up late to be part of this masterclass. Next slide. We're dedicated to wellness. We save lives every day. And some of our guiding principles, this is not encompassing all of those, but we actively engage with nurse leaders throughout the world. We foster global development. We consider the local, regional, and global impact of decisions, and we embrace innovation. We do have a collaboration with the World Health Organization, and we have our UN liaisons, youth leader, and then adult liaisons that work with us in the UN. Next slide. So we serve registered nurses at all levels through the clinical level, administration, academic nurse leaders, researchers, policymakers, and entrepreneurs. Again, we are a global organization and we have it from the undergraduate degree, ADN, entry to practice, all the way to the terminal level. And last slide for me. So just some of our value proposition and what makes Sigma different from other associations. We're well respected. We're known for our quality and leadership scholarship and education. Our programs are mapped to national and international quality standards and competencies. Our members include the finest throughout the globe. They have positions of leadership with decision-making abilities, for program adoptions. And then our products, they fill the gap for comprehensive nurse leadership training. We are an accredited online education provider. We have mentorship opportunities, publications, and conferences. And Dr. Gaea Daniel is one of our authors that has published an award-winning AJN publication. And so without further ado, I would like to take this time to introduce Dr. Gaea Daniel. Dr. Gaea Daniel is an assistant professor at Emory University's Nell Hodgson's Woodruff School of Nursing, where her program of research focuses on understanding the socio-cultural and environmental influences that affect sexual health behaviors and outcomes. She is particularly interested in sexual health outcomes of Black women that present as race-based disparities. Dr. Daniel is an Emory Birch Scholar who devotes her time to diversity-related initiatives in research and the nursing profession. She is also co-editor of the award-winning book, Taking Action, Top 10 Priorities to Promote Health Equity and Well-Being in Nursing. Dr. Daniel is passionate about working with and in the community to serve others. She is a proud member of the National Black Nurses Association and received the President's Trailblazer Award in 2023 for the community-based and research efforts that she has led. So welcome, Dr. Daniel, and I will hand it over to you.
Thank you, Darren, for that warm introduction. And thank you to Sigma and McGraw-Hill for extending an invitation for me to present this masterclass entitled Health Equity, It's More Than Just a Catchphrase. Next slide, please. All righty. Again, my name is Dr. Gaea Daniel, and I too am a member of the Alpha Epsilon chapter of Sigma Theta Tau International at Emory University in Atlanta, Georgia, and I have no disclosures. Before I dive in, I'd like to start with my positionality statement. I am a cisgendered, heterosexual, able-bodied person. I grew up in a rural town in South Georgia that was relatively segregated when I lived there. I am well educated and I work at a well-resourced academic institution. I am a Black American woman. And with that, I'd like to acknowledge that my positionality has influenced this presentation to some extent. I'd also like to acknowledge that the lived experiences of Black American women is not a monolith, and therefore, in no way am I a spokesperson for those who share my identity. As was mentioned, along with my co-editor, Dr. Susan Hasmiller, we published a book entitled Taking Action, Top 10 Priorities to Promote Health Equity and Well-Being in Nursing, which positioned me for this talk. To provide some background for the context for the subtitle, It's More Than a Catchphrase, I'd like to share how I came up with it. So the concept of health equity is not new by any stretch of the imagination, nor is it only relevant to the US. But during the pandemic, when the world was on lockdown and we had lots of time to think and observe, there was a racial reckoning that was ignited by the murder of George Floyd. This was seemingly the first time in my lifetime that the world seemed to stop and take notice of the violent, unconscionable incident that took the life of a Black man, a human being, at the hands of authorities. No, this wasn't the first time this happened, and as we all know, it was not the last. But this seemed to be the perfect storm for people to take notice and acknowledge what was happening. George Floyd's name was mentioned and heard in almost every space of communication. And when it wasn't, it was still on people's mind, regardless of how they felt about the incident. I remember being in one particular virtual meeting where George Floyd and the racial reckoning was being discussed amongst a diverse group. While I was glad the conversation was happening, I started to feel exhausted. Not because I didn't want to hear about it, not because I didn't want to be in that space. I actually liked the people in that space. But what I realized in that moment was that for centuries, minoritized groups, communities, and populations have been shouting their concerns, protesting discriminatory laws and policies, losing their lives in the struggle to be heard. Yet it took a video recording exposing a white police officer kneeling on the neck of a Black man for 8 minutes, 46 seconds by some accounts, while he could be heard exclaiming that he could not breathe. And a global pandemic, which took the lives of an estimated 3 million people that year in 2020, for a lot of people to even realize that we have a problem. And that the stories of the victims of discriminatory policies were not make-believe, because unfortunately, many people thought that before this happened. Now that society has awakened from its deep slumber of ignorance and cognitive dissonance, people have fortunately started to take notice, take responsibility, and take action. The term health equity has become commonly used in a variety of settings, and an abundance of well-funded opportunities have become available to dismantle structural racism and discrimination. I am grateful for that. And I want to make sure we have some level of understanding of what it is, and also that it doesn't become a catchphrase where we use the term because it's popular and it therefore starts to lose meaning. Next slide, please. And with that, I'll begin sharing a high-level overview of health equity by defining what it is. I'll also provide a brief overview of some medical history that led to and reinforced the health inequities and disparities that we see today. You'll hear about social and political factors that determine health outcomes, and then I'll wrap up by providing actionable tips to promote health equity. Next slide, please. So what is health equity? Healthy People 2030 defines health equity as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone with focused and ongoing societal efforts to address avoidable inequities, historical and contemporary injustices, and the elimination of health and healthcare disparities. The Center for Disease Control and Prevention describes health equity as the state in which everyone has a fair and just opportunity to attain their highest level of health. Achieving this requires focused and ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and eliminate preventable health disparities. The Robert Wood Johnson Foundation provides a definition that states health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and other consequences, including powerlessness and the lack of access to good jobs and fair pay, quality education and housing, safe environments, and healthcare. The World Health Organization argues that health equity is achieved when everyone can attain their full potential for health and well-being. And the Health Equity Initiative defines health equity as providing every person with the same opportunity to stay healthy and or effectively cope with disease and crisis, regardless of their socioeconomic conditions, race, gender, ethnicity, age, social status, and other socially determined factors, by identifying and addressing community and group-specific barriers that prevent people from leading healthy and productive lives. Of course, there are many more definitions, so I encourage you to explore those and figure out which one resonates with you. Next slide, please. For the more visual learners, here are two depictions of health equity that remind us not to confuse health equity with equality. In the top picture, everyone gets the same bicycle. While this may seem fair to some, a one-size-fits-all approach doesn't necessarily accommodate the needs of each individual. Instead, a bicycle or tricycle, or a bicycle with training wheels, that meets the needs of each individual rider below, in the bottom part of that picture, yields the desired outcome. On the left side of the lower picture, on the right side of the lower picture, equality is displayed by providing each person with the same box. However, you can see that all the boxes, that they are all not able to see and observe and enjoy the game with the one box that they're all given. The equitable version on the right side of this picture shows that each fan received exactly what they needed, not only to observe the game, but also to enjoy the game. When you are the one with the power and ability to promote health equity through your work, please be mindful of the thoughts and the needs of those you are supporting by asking for their input. Next slide, please. Now that you have a better understanding of health equity, let's move on to the medical history of the health inequities and disparities. In this slide, you will see an illustration of J. Marion Sims, who was at one time considered the father of modern gynecology. For many years, many years, that title and the statues erected in his honor haunted those who were disgusted by his inhumane practices. He purchased slave women to experiment on their bodies by performing multiple invasive surgeries without anesthesia. Consent for these women was not even thought of because they were considered less than human. For me, the irony in this situation is that these victims were not considered whole humans because they were Black and women and slaves. Yet, once the techniques were perfected on their bodies, these same techniques were developed on supposedly non-humans. They were used on white women who were obviously considered human to successfully treat their gynecological issues. It goes without saying that we are all human beings, Homo sapiens, same genus, same species, deserving of equitable care and treatment regardless of our differences. Once slavery was abolished, the Jim Crow era resulted in laws and policies that promoted anti-Blackness for decades. Blacks and whites were not seen in the same hospital wards, and in a lot of cases, not even in the same buildings. Care was separate, but far from equal, and the facilities treating Blacks were intentionally underserved and underfunded. When care was available, it was often unaffordable. Care was overpriced, and insurance companies either charged higher premiums or flat out denied coverage to Black Americans. To make matters worse, Black Americans had limited access to medical education, so that even if they wanted to help one another, they were not always allowed the training and education to learn how to do so. Furthermore, the few health-focused schools that existed to serve Blacks were forcibly closed. Next slide, please. The impact of medicine's history has had a lingering effect, and it's promoted racism at every level. Dr. Camara Jones, a former president of the American Public Health Association, did a beautiful job describing the levels of racism, institutionalized, personally mediated, and internalized, in a theoretical framework. She presents an allegory called A Gardener's Tale that illustrates the relationship between the three levels, and by her account, may guide our thinking about how to intervene to mitigate the impacts of racism on health, and to serve as a tool of starting a national conversation, and in our case, an international conversation on racism. Abuse and neglect are still an issue. Historically, research focused on white men, but when it did include other populations, it was often unethical. These incidences didn't occur just with Black people, like the men in the Tuskegee syphilis trials, where evidence-based treatment was withheld. It also happened with other groups. Many people are familiar with the Tuskegee syphilis trial, but aren't aware that another arm of this research took place in Guatemala. There's also the Havasupai tribe, whose blood samples were used for genetic testing and other research inquiries that were not consented and violated the tribe's belief related to the use of their blood. And we can't forget the prisoners who was exposed to poisonous dioxin experiments in the name of health. False medical perceptions have led to medical myths, like Black people having a higher pain tolerance and thicker skin so they don't feel as much pain. Or they're seeking medications that they don't need, without thought being given to the fact that perhaps they may not have received the adequate amount or proper dose of treatment to manage or treat their condition. All of these factors lead to medical mistrust and distrust. These two are similar, but not synonymous. Medical mistrust is unease or suspicion, usually based on the experiences of someone who shares a similar identity. Distrust is when a patient or client is skeptical about a provider or an institution's intention, motives, trustworthiness, and other desired qualities, usually based on their own perceptions in the moment and possibly previous experiences. Ultimately, these factors lead to health disparities as care is not sought, or when it is accessed, it's not quality, compassionate care. Next slide, please. Moving on to social determinants of health. Healthy People 2030 defines it as the condition in the environments where people are born, live, learn, work, play, worship, and age that affects a wide range of health, functioning, and quality of life outcomes and risk. And the World Health Organization considers it the non-medical factors that influence health outcomes. Most people are familiar with social determinants of health, so I won't get too deep here, but social determinants of health can be grouped into 5 domains, including economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community contexts. Each of these listed here reflect key issues within those 5 domains, and they make up these domains make up the underlying factors in the arena of social determinants of health. Some of these factors include, as listed, polluted air and water, as seen when some communities are positioned near highways, receiving those toxic gases and fumes. Some communities are positioned by, or some communities are chosen and selected to be sites near chemical waste treatment plants. You also have issues with water, like in the Flint, Michigan incidents. Racism, discrimination, and violence. We spoke on that. Safe housing, transportation, and neighborhoods. Access to nutritious foods, physical activity opportunities, education, job opportunities and income, and language and literacy skills. Next slide, please. Political determinants of health is a newer, less used term compared to social determinants of health. Daniel Dawes is a leader and expert in the field and states that political determinants of health involve the systematic process of structuring relationships, distributing resources, and administering power operating simultaneously in ways that mutually reinforce or influence one another to shape opportunities that either advance health equity or exacerbate health inequities. Examples include redlining. Redlining is and was, and in some cases still is, the discriminatory lending practices by banks and financial institutions where they denied mortgage loans and mortgage insurance to residents in predominantly Black neighborhoods and other minoritized communities. This has led to disinvestment in these communities, leaving them without access to healthy food options like fresh produce and without access to health care, which has obviously led to health disparities. Boarding schools for Native Americans were established by the US government that removed Indigenous children from their families and their communities, all in the name of forcing them to culturally assimilate. I cannot begin to imagine the amount of physical, emotional, and psychological trauma these children and their families experienced and endured. The intergenerational trauma is probably immeasurable and is directly evident in health disparities. For the last example, eugenic laws were enacted to forcibly sterilize people so that they could no longer have children. And these people, they were looked upon as undesirable or unfit for society. Racially minoritized communities, as well as people living with disabilities and those who were of low socioeconomic status, were disproportionately targeted. And in a lot of cases, these procedures were completed unknowingly to the victims under the guise of standard medical care. Next slide, please. The Kaiser Family Foundation does a great job bringing all of this together with this figure to show that health disparities are driven by social and economic inequities. Importantly, they have racism and discrimination positioned as a mitigating factor. I want to highlight that although this presentation focused heavily on Black Americans, racism can happen to other minoritized groups, and discrimination can occur regardless of your race, to include socioeconomic, geographic location, whether you're rural, urban, low middle income country versus high income, gender, and sexuality identity. All of these are proof of this, and they're exasperated by stigma. I hope that you will take some time to go back and view this recording so that you can dissect this figure to understand how it applies to your life specifically and the lives of others around you. Next slide, please. So as the name of our book implies, we encourage you to take action. This book is a collection of more than 70 nurse leaders, national and internationally, and also up-and-coming leaders in the field of nursing. They share their personal and professional stories about their experiences with health equity in nursing and experiences with well-being in nursing. So I want to encourage you to take action by engaging and advocating. So what does that look like? Voting and policy. I encourage everyone to vote. I encourage everyone to empower others to vote. Policies, as you saw from the political determinants of health, policies can influence health disparities and can hinder or promote health equity. I encourage you to join organizations. Organizations usually have an action arm that are focused on promoting health equity. And you can even go a step further than joining the organizations by also becoming a board member and helping make decisions and joining committees to take action. Community-based activities. Nurses possess a unique skill set where they are able to communicate with laypersons about all things health. And so with that, I encourage you to get out in the community and help educate community members about health and health equity and all things related to health so that they feel empowered to advocate for themselves when they show up at a provider's appointment. So they're informed, so they know they have options. I also encourage you, like I did earlier, to seek community-based input so that when you're designing research projects or interventions, or when you're designing ways to support groups, you know what they need. You can meet them where they are. You can meet them where they want to be. You can help promote health equity. And then you want to seek to eliminate barriers of care. And this is especially for people who have power. You want to be able to provide that blue phone that I had when I was on the unit working at the bedside that allowed translation when I did not understand the native language of the person I was caring for. Next, you have education and training, which includes implicit bias and cultural competency and humility. So the brain has this way of naturally categorizing things so that you don't spend too much time focusing on each individual thing as a matter of survival. Way back in the day when we were cavemen and women, we needed to assess quickly. But now our body still functions in that way. We still have that innate ability to assess quickly, but that also leads to implicit biases. So even when you know it's wrong to respond, there's something deep within you that you're using that uses stereotypes to analyze a situation, and you make decisions and you move based on those stereotypes that you've come to know. It's not listed here, but I also do want to mention that explicit biases are a thing as well. There are biases that are intentional, that are reinforced, that are taught, that are deeply believed and deeply held. So we have to acknowledge that as well. Next slide, please. Oh. One other thing I wanted to acknowledge on that slide that we just left, I'm sorry, cultural competency and humility. I want to be clear that competency does not mean that you know everything about someone's culture. It means that you're open to learning, you're willing to learn, you want to learn, you care, you provide compassionate care. No one expects you to completely know or be immersed in or understand everyone else's culture. You can only be an expert at your own lived experience. So with that, with cultural competency and cultural humility, practicing that will allow you to expand your scope, will allow you to be more accepting and receptive of other people's culture, and ultimately lead you to provide better care. Next slide, thank you. Another tip, practice self-reflexivity. It's not just about reflecting on what happened. It's actually a practice of making a conscious effort to dissect and analyze how you show up and how your perceptions and actions have an effect. So you want to move beyond reflection with this. And one way to do that is the positionality statement, like I gave at the beginning of this talk. So you can know from which lens I was presenting from. You can know a little bit about me, my lived experiences, my thought process. Another thing you want to do is recognize and acknowledge privilege. I know that some people are a bit uneasy with this, but acknowledging privilege doesn't mean you wield your power for evil or anything like that at all. Acknowledging it allows you to, going back what we said about practicing reflexivity, it allows you to center who you are, where you are, and to acknowledge that privilege allows you to reach back to those who are less privileged and bring them along. Acknowledging your privilege helps you realize that everyone doesn't have the same opportunities that you have. And I want to reiterate that this is not just based on race. This can be based on your position at a company. This can be based on your ability. It can be based on several different aspects, several different social aspects. But the key to it is recognize it and acknowledge it and use your privilege for good to help others achieve health equity. The next thing is to decenter whiteness. This is not at all about shaming whiteness. It's about creating a culture where whiteness is not necessarily the gold standard or the measure of success. We all have our own journey to health equity, and our care that we provide as nurses should be individualized to reflect that. Next, you want to be intentional with your care. You want to incorporate a biopsychosocial model. It's more of a holistic approach to care that includes the biological aspects, the psychological aspects, and the sociological aspects when assessing and treating patients. So people aren't just one-dimensional. And with that in mind, you need to kind of pluck and assess a lot of different aspects of their lives to develop the care that is appropriate for them, where they can achieve health equity. And then to collaborate with other providers. Please, please, please collaborate with other providers. It's impossible for you to know everything. No one expects you to know everything. Collaborate with other providers to get their views, their experiences, their input on how to manage a patient, how to treat a patient, especially if you don't necessarily align with the patient socially. Having the collaboration of another provider that understands where the patient is coming from or may share the same background as that patient will provide you an opportunity to provide culturally competent care. That's also a plug for diversifying the nursing workforce. The more diverse it is, the more culturally competent care we can provide, and we can teach one another. And then lastly, be aware of resources. Going back to the biopsychosocial model, that social piece is often left out. Thinking about how you provide prescriptions, you tell people what to do, but then you never follow up to see if they have the resources to fulfill the actions that you prescribed or that you encouraged. It's very important, and I'm a huge, huge fan of social workers. Get to know a social worker. They're extremely resourceful. If a patient shows up and you prescribe a medication and they're unable to afford it, that's something you will want to assess when you're prescribing that medication. Can you afford it? Can you get to the pharmacy to get it in case you don't have a pharmacy located at the institution where you're practicing, at the establishment where you're practicing? A social worker can help you create a list of resources for patients when they come in with these barriers to health equity. Next slide, please. I want to wrap up by highlighting the importance of health equity, starting with health equity is a human right. I'll repeat it. Health equity is a human right. We are all deserving of equitable health. Health outcomes are improved overall with health equity. When those who struggle the most are happy and healthy and live a full life, then obviously everyone else who's not struggling as much will also do better. Promoting health equity decreases the burden on the healthcare system. Think about it. In an equitable society, people have access to care, regular care, preventive care, so they don't necessarily show up at the hospital overwhelming the system when all they needed was a primary care appointment instead. It also decreases the burden on the economy. It's very costly when people show up in places to receive health care and they can't afford it. But health equity allows for that affordability and therefore decreased burden on the economy, because that pay and that loss of funding does not fall back on taxpayers and the healthcare system. Decreased burden of disease. So if people have access to healthcare, they can be treated, they can manage their diseases, and therefore decrease the burden. Prevention and early detection is key to promoting health equity. Again, having access, having transportation, having the funds to pay for these aspects of care are key to helping us thrive related to our health. And studies show healthy people live happy lives. And the opposite is also true. The converse is also true. Happy people live healthy lives. So when you're feeling kind of down or sad or mad, you can literally start smiling and you start to feel better. Try it next time. And lastly, it's the right thing to do. It should be, as a nurse, your moral obligation, your duty, your will to promote health equity because it is important. Next slide, please. I'd like to leave you with a quote from Dr. Martin Luther King Jr. that many of you may already be familiar with. In 1966, he said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." This quote is still relevant today and will most likely continue to remain relevant throughout my lifetime. So to that, I'll say, keep pushing, keep taking action. Next slide. And while you're out there promoting health equity, don't forget to remove the barriers like the fences you see on the left in people's lives, and to provide support where it is needed so everyone will have the opportunity to eat apples, like on the picture in the right side. You have the power to not only promote health equity, but to also foster justice. Thank you again to Sigma and McGraw-Hill for this opportunity. And I want to give a special thank you to all of you who took the time to join the call today, and to those of you who will review the recording afterwards. I am humbled. Thank you.
Thank you so much. Can everyone hear me? See some nods. Yes, big round of applause for Dr. Gaea Daniel. Gaea, I apologize for saying your name incorrectly earlier. Thank you so much for that fabulous session. We are not done, so if you have questions, I've seen some really good comments in the chat. Clearly, this is a presentation that's inspired a lot of thoughtfulness. So if anyone has a question, this is the time. Dr. Gaea is here. She's ready to answer your questions. Let's see. I have a few also that I can ask while people kind of percolate. So let me see here quick. Oh, we're getting a lot of thumbs up, a lot of thank yous. So I'm going to take a minute for it to settle down to ask any questions. One thing I would love to ask about, and maybe it's because this is Kaylin from McGraw-Hill, so I'm interested in publishing and the community that you built in putting this book together. Can you tell us about that process of bringing together those 70 plus leaders and experts?
Sure. So it was absolutely a labor of love, something Sue and I were excited about, just putting it together and getting to network and get to know each of the authors. Some of these people, we would have never imagined the stories that they told. We had no idea about their backgrounds. And so it felt really special that they were willing to share and willing to open up. And I hope the viewers will take a minute to get the book and take a look at the stories that the people are telling. It's really engaging, but the people who contributed were so grateful and enthusiastic about doing so. Like, we didn't have to pull teeth at all. They were just like, of course I'll do it. And so we felt very grateful for that opportunity. Um, you can purchase the book on the Sigma website, the Sigma Marketplace website, and feel free to leave feedback. We'd love to hear how you respond, what your thoughts were with this book, and how it made you feel. If there were things in the book that you're able to incorporate into your nursing life, into your non-nursing life, for that matter. But yes, it was a pleasure. It was a joy. I do want to add one quick thing that we tried to be very intentional about how we selected people. Um, we have some well-known names, but we also wanted to make sure that we got the names of people who did not have that recognition into the book, so that different perspectives from all levels of nursing, all levels of leadership would be reflected in the book. We wanted everyone to be able to relate.
Thank you so much. Can you hear me with less static now? Maybe?
Yes, I can.
Thank you. There was a wonderful question, and the comment preceding the question is, hello, thank you, Dr. Daniel, for your thoughtful presentation and your energy. What are your thoughts on differences between cultural humility and competence?
So competency is kind of tricky, because when you think competence, you think like, I know this, I know everything. And so for me, like I mentioned in the presentation, it's not exactly that. And it's important that we recognize that. So I like to think of the two as complementing one another, with humility being showing people grace, being open to learning about people as individuals. Um, I do want to encourage you, I didn't say this in the presentation, but a lot of us in our work environments, they have all of these trainings about implicit bias, cultural competency, cultural humility. I really want to encourage you to stop and take a moment and actually read through those, process them, think about them, do a little self-reflexivity. Don't just check the box just to get it done. I know we're all busy, but this not only makes you a better nurse, but a better human being overall in your interactions with people on a day-to-day basis. Thank you for your question.
All right, do we have any other questions? I have one, which is, I love that you brought up again that self-reflexivity. I think one thing that just from the beginning even of your presentation was so powerful was that positionality statement that you led us with. Do you have any tips for us on how we could create our own, or could you talk about the process of creating your positionality statement?
Yes, absolutely. So it is a very humbling experience, and you start to recognize your privilege. When you see me, you see a Black woman, you may think discrimination, you may think of things that I've suffered from, you may think of health disparities, and all of that is really true. But to position myself in this space at this time, giving this presentation, I am a person of privilege. So I have to recognize that I have access to hundreds of listeners. I have access to an abundance of resources at the institution where I conduct my research. And I know that that's not the case for everyone. And so it's important to frame that accordingly so that people understand where you're coming from, your lens, and they're less likely to assume that your intentions are bad. And so in creating that, I actually did some self-reflexivity, and I centered myself in the world that I am living in the world that I exist as it relates to this presentation and this webinar. And I started to break down my identities, the different ways I identify. And I wrote that specifically for this presentation because I wanted it to be specific to this presentation. And so I encourage you, when you give different presentations, to have a little variation in your positionality. This wasn't necessarily the place where I had to disclose that I was married. That wasn't really relevant. So think about how the way you're presenting, whatever it is you're presenting, or how you're showing up in the room will be reflected in the work that you're sharing.
Thank you. I have another question here. Why is it important to apply an intersectionality lens individually and organizationally?
Yes, absolutely. Great question. So, thinking about intersectionality, I'm thinking about all the different identities that I hold and realizing that in some cases, the identities that I hold are not seen as an individual. And so when they are seen intersectionally, they compound on one another and create a larger effect than they would if I looked at each one of them individually. And so thinking about that, you think about a person's individuality and how their different identities come together, and you look at their lived experience and you can better understand why they make the choices they make. And especially related to healthcare and health equity, you begin to have more sympathy, more empathy, more importantly, when working with them or treating them in the case of providing care. Organizationally, I think organizationally, I would look at the different identities of a company to see if I want to be affiliated with them, to see if I want to interact with them, in some cases, to see if I want to spend my money with them. It can be a direct reflection of the ethics, the mission, the values of an organization. And I think those are important to acknowledge and to recognize and dig a little deeper into to see if they align with how you feel before you spend your money, before you invest, before you take a job there even. Thank you for that question.
Great answer, too. Thank you so much. We have another question, which before I get to that question, we've had a few excellent questions about where you can buy this book, because I'm encouraged to buy the book as well. And so it is available. We've put a link in the chat where you can buy the book in the Sigma Marketplace. The book will eventually be available as well on Access APN, so Access Advanced Practice Nursing from McGraw-Hill. So we have links in the chat to both purchase that book as well as to get a demo or to access Access APN. So just wanted to answer that real quick. All right. The next question. So someone here writes that they have a question about where to start in a country that doesn't recognize health equity because healthcare is free. Of course, inequalities exist, but they're talking about dealing with the denial. So what type of studies can help them get started with some actionable outcomes?
So that is a situation I am not familiar with, being an American, but I deeply appreciate that all people have access to healthcare. As I mentioned before, it is a human right. And so with that, I would begin to think about more deeply. So superficially, when we think about health equity, we think about access. So I would start to look more deeply into the interactions within the healthcare system, within how people are provided care, the way people receive care, just all things related to the actual interaction between the healthcare system, including the provider, the respiratory therapists, the pharmacists, all these different aspects. But think about those particular aspects of healthcare that contribute to health inequities. And also think about the social and political determinants of health. That's not directly related, that's not always, well, in this case, related to access to care, but it looks deeper. So while people may have access to care, they may not have access to safe neighborhoods. So if you're afraid of being hurt or raped or kidnapped in your neighborhood, you're not going to go out there and walk. You're just not going to do it because you don't feel safe. And so thinking about access to transportation to get to the healthcare facility, that may be an issue. So there are other issues. I know we often tend to highlight access to care as one of the main issues for health equity. That's hindering us from promoting health equity, but there are a lot of other aspects based on laws that are generated and other discriminatory practices that may affect health equity. And you can focus there. One of the quotes I gave was by Daniel Dawes. He has a beautiful book on political determinants of health. There's a book by Dr. Callie Smith, Jim Crow in the Asylum. It talks about the mental health disparities experienced by people living in the South, those who, how white people were in a medical facility for their mental health, and it was like a day at the park, whereas Black people were in a medical facility for their mental health care, and it was like prison. So being able to dive deeper into those unique differences that may be specific to your facility, not necessarily exactly what I'm saying, but it will at least give you some insight on how to tease out and how to look at the disparities between different populations, different groups, different, when I say groups, I mean like all the social things, age, socioeconomic status, ability, all of those things. But those types of books will help you frame and be more intentional about how you approach it in your country. Thank you for that question.
Thank you for the very thoughtful answer, Dr. Daniel. Unfortunately, that is all we have time for today. If we didn't answer your question, we will do our best to connect with you. Thank you so much to everyone who spent time with us today. We really appreciate it. I'm looking forward to hearing more or seeing more on how you plan to take action to promote health equity and well-being in nursing. I see a question about evaluation. I don't believe that there's a survey following this session, but we would always love to hear your feedback. I've put, there's a couple emails in the chat. I will share mine again, which is an email where I am happy to direct you to the right people. So thank you again, Dr. Daniel. Thank you so much, Darren. Thank you to Cynthia from McGraw-Hill. Again, I'm Kaylin Creason from McGraw-Hill. If you have any questions, please email us or check out either sigmanursing.org or mhprofessional.com/APN. A link to the recording will be sent out, so you can also, and there will be a survey. My marketing manager has just informed me. So please share your feedback and let us know any questions or feedback you have. Thank you so much.
Thank you, Dr. Daniel. Thank you, Kaylin and Cynthia as well. Great job.
All right. Thanks again, and everyone have a fabulous day.
Bye-bye.